right, so I will go ahead and just kick us off. Like I said, Assalamu alaikum and welcome everybody, especially to our distinguished speakers. Thank you for joining us on the Sunday afternoon. My name is Nabil Khan, and I'm working with Worry Free on the EMPART project. And these meetings that we're having once a month on Sunday afternoons are all part of that project in an effort to sort of build partnerships across various stakeholders interested in improving Muslims' well-being in the Chicagoland area. Today's topic is going to be around partnership, and we're going to sort of, Sister Fatma is going to relate that to the expand on that as a key P core principle. And I will, for the speakers, I know these things can be a little bit tricky. I'll try to keep people, I think each speaker will have about 10 minutes. I'll try to remind you when you're like nearing the end of your time, but probably just through chat. Yeah, I know you may or may not be able to see it when you're in the middle of presenting, but we'll try. And then with that, I think I'm going to hand over to Brother Saif for the dua.
Assalamu alaikum. Good afternoon.
Sorry, just a second. Go ahead.
Assalamu alaikum. Good afternoon. Can you hear me?
Yes.
I apologize for kind of being out of the loop, but hopefully I'll be able to get more involved. But I'll start us off with the prayer. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم اللهم ألف بين قلوبنا وأصلح ذات بيننا واهدنا سبل السلام ونجنا من الظلمات إلى النور وجنبنا الفواحش ما ظهر منها وما بطن وبارك لنا في أسماعنا وأبصارنا وقلوبنا وأزواجنا وذرياتنا وتب علينا إنك أنت التواب الرحيم. O Allah, God Almighty, put affection amongst our hearts. Set right our matters between ourselves. Guide us to the ways of peace. Deliver us from darkness towards light. Save us from all kinds of indecency, the apparent as well as the hidden. And bless our hearing, our seeing, our hearts, our spouses, our children, and accept our repentance. Indeed, you are the one who greatly accepts repentance, one who is repeatedly merciful. Ameen.
Ameen. Jazaik khairan, Brother Saif, for the dua. The whole idea with the dua, everyone, is that we add the intent behind when we start to do anything, and this intent is actually more has helped, and studies have shown actually that when you put the intent behind something, you're more than likely to complete it the way you want to do it. So inshallah, we hope that with this intent, we would be blessed with the partnerships, and we would do the right thing, and these partnerships will bear fruits, inshallah. I just want to review the meeting format. We're actually doing 6 meetings in this series. This is part of the EMPART PCORI funded project, as you may have read about this particular funding institution. So the 6 meetings correspond to the 6 PCORI principles. And what we do is every meeting, we do one principle at a time. Today's principle is about partnerships, and when we highlight how to use a particular principle in your work. So how do we incorporate partnerships, whatever we are doing, and build around it? So with that, with the principle in there, with the value in place, we add the intent, and hopefully, inshallah, we expect to achieve things. We have great speakers today that have actually demonstrated partnerships building and have proven best practices by which they have adhered to these principles and have worked in the community very successfully. And then we would want to leave about 30 minutes or more for the Q&A with the speakers. Just a brief introduction for those people who are joining us for the first time. The EMPART is actually the second project in the series of Mosque PICOR project. Mosque, you probably know that the places of worship, and then the PICOR is patient-centered outcomes research. So we have adapted the patient-centered outcomes research methodology and its methods and its principles to apply that into a mosque setting. So the very first project actually was funded back in 2017. It was a 2-year project. We produced a toolkit, which is right here, Mosque PICOR toolkit, and that's what we took from that. From that point, we're now taking the toolkit, disseminating it into the communities and into the mosque community environment by training people, by telling the mosque boards and other community members, community stakeholders, as to how we put the patient-centered outcomes research values and principles into a mosque-based setting to bring people more towards health and well-being. So the second study that was funded was actually to disseminate this toolkit. It's a 1-year project from August last year going on to October. We have actually taken a 90-day extension because of the COVID situation. And hopefully we would be culminating this with a second conference. The first conference happened in 2019. The second would happen, inshallah, this year in September. And we're now in the outreach phase, but we would be doing health equity town halls in the month of June and July. And we are looking forward to have all community partners on board with the data and with some of the key practical items to work to dissipate the health disparities within the targeted communities. The timeline, as I've mentioned, right now we're doing the outreach. It's called VertReach because it's the outreach that's happening online. It would go on till May of 2021. There are at least one community health worker on the phone call, which is answering questions to the public. This would happen all the way up until May. And then in June and July, we would be moving on to the health equity town halls. And then in September would be the meetings. So some of the key virtual outreach activities are actually the community health workers are taking phone calls and talking to the community members, guiding them for whatever their needs are. There's a flyer that we have. You can take this flyer and actually send it out to your communities as well. The community health workers are coming from a Muslim perspective when they are talking to the Muslim client, but community health work is the same regardless of what community they're serving, because healthcare really is indifferential to any race and ethnicity. People can also chat by going online to the Worry Free community, and they can send a question to the community health workers. They can respond that way too. And the nonprofit and healthcare and businesses and organizations can also join us in the project by going to the worryfreecommunity.org website and signing up with their programs on the form that's already online. It's called Be on the Map. So anyone can sign up with the programs. Even I would recommend that Advocate Christ Medical Center can also sign up with some of their programs as they cater to the mosque communities in their area. So it's a great resource. It's a free online directory. The key principle that we are hoping to work with today is active listening. I just want to say a couple words about partnerships. I just want to say a couple words about, I personally have found out that active listening is the hallmark for creating partnerships. And leadership development is actually one of my key favorite subjects. And everyone is familiar with the Stephen Covey's The 7 Habits and his leadership books. And really some of these things that I've I've uptaken into my practices has really helped me a lot. And not only just me, it has helped the entire organization come forward with its mission and goals. So I actually look at active listening is a continuum, and listening itself is a continuum. But of course, ignoring and pretending to listen is not a part of active listening. But even with selective listening, as we talk about it, it's only half the active listening. But when you go to these levels of attentive listening and empathic listening, that's when you are actually being attuned to what the other person is saying, and trying to work with where they are coming from. So that's what the key is I found out personally that that's the key when we are creating or initiating partnerships. I found out that one of our key factors in the communities that I'm dealing with, we are still struggling with, where we're stuck at the first level of partnership creations. Many nonprofits, they're doing excellent work and great work. However, many of them are also silos. And that's where we're at as a community. We have to understand what these broken links are in order to overcome how to move forward from that point on and creatively work together. Unless we work together, we will not serve the community at large. That's the key. And I found out that active listening is really one of the key. So I would encourage everybody to take a deeper dive whenever you have some time into Stephen Covey's literature and listening continuum. I love this diagram, by the way, so I share my favorite pieces with you guys. So thank you for letting me share. Let me take a moment to introduce Ms. Melissa McGuire. It's an honor to really introduce her. She's familiar to all of us, and she's really dedicated to the free and charitable clinic cause, not only at just for the grassroots level, but I call her really the queen of building partnerships. She has been serving as an executive director of Illinois Association of Free and Charitable Clinic, and she has literally taken this mission to a great extent, where she helps the nonprofits create and initiate leadership partnerships at a strategic level. That's the key. Once you strategize in partnership with an existing healthcare system or existing nonprofit, you have to then establish it and then build a relationship to move forward to together build the programs. So Melissa works at the entire continuum. Whenever you ask her for anything from the strategy to the operational, she has an answer for that. So it's really an honor to listen to her. And I've taken many lessons from her. Every word she says, it's just unbelievable. So she's a blessing. Thank you, Melissa. And I'm gonna give this to you, and you can share your thoughts with the community. And after Melissa's sharing her thoughts, we would have doctors, Dr. Tahir, Dr. Okbanjo, and Dr. Okoli sharing how they are working with the Christ Medical Hospital and the nearby communities and what programs they have for the communities. So thank you, Melissa. All to you.
Thank you very much. Should I screen share and put my slides? Okay. So while I'm getting my slides on, I first would like to give so much appreciation to Christ Hospital Medical Center from a personal and a professional basis. Probably have the same story that many of you have had, in which my family members have been cared for and also transitioned from life through Christ Medical Center. And the compassionate care that my family members have gotten from my father's last breath, with my mother and I not wanting to leave his side, and somebody said, go and get a cup of coffee and I'll be holding his hand when you come back. And when we walked back in the room, there she was holding his hand, and we were able to be with him when he transitioned. To my brother going into the emergency room, realizing he thought he was paying his health insurance and he wasn't. And he was panicked at Christ Hospital's in the emergency room that as he was in congestive heart failure, he was not going to get quality care. And the nurse literally put her head on the pillow next to him, So he couldn't see the monitor. And she said, I don't care about your health insurance. I care about you. And so for that, I just want to say a world of gratitude to Christ, as well as on a another personal note. My church has been involved in Christ Medical Center in many different ways, and we have members on the board there. So to be on a call with this amazing team means a lot to me. To also be on the call with Fatima and Nancy means a lot to me, because they are doing what I believe to be true medicine in the community with the people, listening and providing the care. So for me to be able to talk about partnership, I first have to acknowledge and humbly address those of us on the call. Can you see my slides?
Melissa, you have to present.
I have to present? I thought I just did. Okay. What do I do?
You have present now.
Okay, don't look at my desktop, okay? Because it's kind of messy.
Sorry.
Don't look. Okay, can you see my slides now?
You have to say present now and then say share screen.
Oh, I'm so sorry. I'm a Zoom person, so I'm learning.
Sorry.
Oh, no, share. I have present now.
Yeah, and share screen.
It doesn't matter. I mean, I can just, your entire screen. Okay. Chrome wants to share contents. Choose what you'd like to share. Oh, I want to share this.
Yeah.
Well, now that's silly. Share. There we go. Where are we?
Oh, beautiful. You got it.
Yahoo. Okay, I'll talk fast because I know I want to make sure. What can you see?
Yes, we see your screen and the EMPART. So you can go to the EMPART. Yeah, there you go. Perfect.
I am presenting to everybody. Okay, can all you see is my slides now?
Yes, you can maximize the screen. Yeah, perfect.
Okay, now I'm going to do start slideshow. All right. Okay. All right. So basically, what I would just like to talk about in a short period of time is just humbly a few of the things that I've been able to benefit from. I'm not a medical provider. I'm a social worker. And in the 30 years that I've done social work, I really believe that partnership is the bridge. I would like to share one of our clinics when they were talking about when the COVID vaccine came, one of our free and charitable clinics when the COVID vaccine came. They said, it feels like I'm on the side here, and in an island, I see my resources, and how do I get to my resources? And I really do feel like partnership is the bridge for accessing our resources. I'll just do a quick overview. We have 52 free and charitable clinics in Illinois, and they range from freestanding to mobile to virtual. And of our clinics, here's kind of the breakup of the patients. The demographics of the patients that are served by our free and charitable clinics, their socioeconomic status. 100% of our clinics serve those that are uninsured or underinsured. I've got to say, with the COVID, what our clinics are seeing is newly emerging underinsured, people who have not been underinsured or uninsured prior, and so they're trying to manage their healthcare in the midst of a pandemic. And your model is perfect. What you are doing to address that really, really meets the needs of the newly uninsured and the newly underinsured. The health conditions of our patients, this was done in 2019 prior to COVID. The health conditions that our clinics address: diabetes, hypertension, hyperlipidemia, obesity, and asthma. So our clinics are addressing chronic health conditions. What's not on there is that what we know is when we are starting to partner with or understand the healthcare benchmarks, like how our clinics are faring. Actually, the patients in free and charitable clinics are actually doing as well or better than patients that are in federally qualified health centers. So free and charitable clinics are not federally qualified health centers. They're private 501c3 that rely heavily on a volunteer core, which is amazing to see this great partnership for the volunteer core. So let's talk about creating partnerships for effective patient engagement. So this is my yard. I thought it'd be nice for us to see green today with a little bit of white. And over in the right-hand corner of this yard, you can see a little stump and a tree. And right there is kind of what happened is we had a tree that got struck by lightning, and right around the base of the tree, we had just, nothing growing there. And so to me, that's kind of like what partnerships, it starts as a blank slate, right? And you kind of want to be able to be creative and try to figure out what's going to happen with this partnership. And I think for partnerships, it's really, really important for us, just as you did this meeting, that we always want to keep top of mind, what's the mission? And if our mission is to engage patients in either care and or engage patients in research, we always want to keep that top of mind. And also with partnerships, we also want to talk about what are our initial goals and objectives, and know that when we're creating this is a fluid process and this can be changed. I also think it's important to keep top of mind, how is this partnership going to function? Is it informal or is it formal? And both are good. An example that I could give of an informal partnership that I found to be really, really helpful and beneficial was when I was opening a shelter for pregnant and parenting homeless teens in Chicago. I worked for the night ministry for 15 years before I came here. We could not get our girls, that's what we called our girls in the shelter, we could not get them to take long-acting contraception. All the research said that was the helpful and most effective way to extend the time between pregnancies, is that these girls would take long-term contraception. And for many reasons, valid, they didn't trust the healthcare system to take the long-term contraceptive. So what we ended up doing is we had a partnership with a doctor through Heartland Alliance. They do healthcare for the homeless. And whenever we had more than 3 to 4 girls available in the shelter, she would show up and she would have a session called Ask the Doctor. And basically they could ask the doctor anything. And she just did that periodically. And after she developed the trust with our girls, then she would say, how about you look at, and then she would talk about long-acting contraception. We also looked for a doctor that looked like our girls. They need to see the people that reflect who they are in order to be able to trust the messaging that's coming from them. So that informal partnership really, really worked. There are also importance if we're looking at patient engagement for formal partnership, and that's really important if we're looking at something that we might have some research attached to it, or something that we're looking for some sustainability. So who do we invite to be part of our formal partnership? We want to invite people that share our mission. It's also helpful to invite people that expand the reach of our mission. And also it's key to understand if someone's going to be in the partnership, that they understand the process, that it's going to take some time. You want some people with some patience. And that there's a key aspect of the creating stage that we are trying to be able to evaluate our process. It could just be a touchstone after 2 or 3 meetings. How are things going? What's working? What's not working? Are we meeting our mission? Do we need to invite others? Are we missing the mark? So I think that's kind of the creating stage. So we have this blank slate, or if you look in my garden, kind of that little flower bed over there that has nothing on it. When we talk about establishing our partnership for effective patient engagement, what we want to look at is, this is where we get to the point of clarity and purpose of defining our roles and responsibilities. You might not want to do that very in the beginning. You're just kind of testing things out. But as you start working together and as you start saying, okay, we are sharing this mission, then really what you want to do is start having more clarity. And that's where you talk about, how do we communicate? And totally support what Fatima is saying about active listening. What are our roles? And you also want to understand, and we also want to understand that our roles are in the initial roles and they evolve. To include the voice of the people you serve is critically important. So one example I'd like to give back to when I was working at the night ministry, I was fortunate enough to be part of a group with Northwestern and Rush that was designing a cell phone that had resources for homeless young people. Now, this was 8 years ago, prior to COVID, prior to all of this, and people were still kind of hesitant to understand what cell phones are. And the conversation we kept saying to ourselves over and over and over and over again is, when do we involve the homeless young people in the iteration of the cell phone program? And so when we thought it was right, when we decided we had like the bones of the structure, we said, now it's time to invite these young people that are experiencing homelessness into the conversation. And we say, we have this great cell phone and it's going to have an app and you're going to be able to find shelters. This was, cutting edge 8 or 9 years ago. What do you think about it? Well, the first thing I wanted to say about this is it's very important to have partners in your process that when we understand our roles to be patient. It took about 4 or 5 meetings before the young people actually showed up. We just kept having the meetings till they came. We just keep having the meetings till they came. We also had to have an incentive for them. And I'm not opposed to giving people incentives. Their time is valuable. So we said, if you show up to this meeting, you'll get a prepaid phone card. And after they attended 5 meetings, they got a cell phone with the program in it. My thing about involving partners is if you involve people in research, you only want to involve the people in the research if they are getting a benefit from it, right? Like even to be part of the conversation. So finally, after 4 or 5, meetings that nobody showed, finally they started coming. They looked at what we designed, like, oh, this is all great, this is all good, but what you don't have is the opportunity for us to talk to each other. That young people that are experiencing homelessness know tons of resources. So yes, you have these nice things and these nice things on the HMIS website and nice things, but I'm not going to trust that shelter unless a peer or a friend of mine says it's safe there. So we were able to redesign parts of this cell phone app that identified resources because of their input. And I think that the roles of involving the patients, the roles of involving the people we serve is really an important conversation to have. The other thing about a partnership that I think at this stage are, what are the key benchmarks? How are we going to know that we are successful? And what's really helpful in some things is that what Fatima talked about is toolkits, resources. It's helpful to have kind of tangible things. I think that the partnership can put their hands in and say, okay, this is how we're making progress. I'm not opposed to that. I do think that it's important that we be flexible with the benchmarks and that we also put time in the benchmarks where we show our products to those people that we're actually serving in our mission, which are the patients. And then this is the garden at the end of the spring. This is how things can flourish. If we have a great foundation, if we have some clear roles and define things, if we kind of keep watering, if we have some kind of ability to be flexible, then we talk about how do we sustain this for patient engagement. So if we say, okay, we're going to work together and we want to engage patients in either our research, we want to engage patients in our care, we might have formal sustaining relationships, or we might have informal sustaining relationships. And I would say the exciting thing that I would talk about is our conversation here. It started with Jackie Rouse and myself having an informal, not your wonderful, amazing EMPART. I'm not talking about that. I'm saying my invitation to be part of this amazing group started with a meeting I had with Jackie Rouse, who was at Christ Hospital at the time. And basically, we just wanted to meet each other. We just knew we had a shared mission, but we didn't know where it would fit. And we just said, let's just keep each other involved in each other's activities and things that are going on with each other. Well, now to this day, I am pleased and proud to say that not only this great care that Christ Hospital has provided for my family, Christ Hospital, through Advocate Aurora, has reached out to the free and charitable clinics and provided flu vaccines when they have some. They've reached out to the free and charitable clinics and they've said, we can sign up your providers to get in our portal for the COVID vaccine when it's available. So it became from informal to formal through relational work back and forth. So how do we make that sustaining? It's important if we go formal to have timelines, but it's also important to be flexible. It's important to be honest with ourselves and others, and to say when it works and when it doesn't work. IFCC is big about work groups. We're big about talking with our clinics. And it's important that when we do our work together, the clinics are benefiting from the work group as well as the patients that they serve. And we always want to have critical evaluation throughout the way. I'm really cognizant of time, so I'm trying to talk really, really fast. And I can't see the chat, so I hope I haven't gone past my time.
No, you're good. You still have 5 minutes.
Oh, yay. Okay. So what I would say about sustaining, let's talk about the sustaining part, right? Fatima, is that what you're saying? Is that's kind of the key that we want to focus on right now?
Yeah.
Okay. So I would say when we're talking about sustaining a partnership, it's critical that we understand what parts of this partnership that we want to sustain that could continue to be an informal, right? And so if we're going to continue to have an informal working back and forth with our partnership, one of the things we want to look at is, okay, I'm just going to keep you on my email list, and when information and news comes, and Fatima's great with that, I just get emails all the time. What I like to think about informal is, my son was in improv. And if anybody knows anything about improv, one of the rules of improv is there's this understanding of yes and. Like, you don't say no to anybody, you say yes and. And so I think that's kind of the key of an informal relationship for partnerships. So somebody said, as long as it's fulfilling the mission of engaging patients or patient engagement. So I would say for the informal, try to keep it like an informal improv, yes, and, but also be able to say, okay, there are pieces of this conversation that would work. When we get to the formal patient engagement and formal relationship, I think it's critical that we are really, really honest with what we're trying to accomplish and what burden and or resources we give to our patient. So if we're going to ask our patients to complete an evaluation, or if we're going to ask our patients to complete a research form, what do we do with that information that is to their benefit? And if it's not to their benefit, do we need to ask them that question? So an example, again, back to my world when I worked with homeless kids, is we got a grant to survey young people that were experiencing homelessness on the streets of Chicago. And we were, in order to receive this money, we were supposed to ask these young people 120 questions on the streets. I can't see you, but I'm hoping you're all laughing out loud. So one of the things we had to do back and forth in our formal negotiation is say, if we ask these young people that are experiencing the homelessness these 100 questions, and they ask us for housing, and we don't have housing, we can't, then you're really much abusing the person that you're asking the questions for, right? So, so what we want to do is be really, when we're talking about patient engagement, or we're talking about involving patient in research or evaluations or questionnaires or surveys, we want to be cognizant of what are we going to do with that information, and whatever we ask of them, what can we do with that information, right? I think it's important. There are times when we can engage our patients or engage people in information and resources that don't pertain to them, when we have a relationship with them, when we show them respect, and when we're honest with them, right? And I believe that that can be done with a smaller group of patients, but not like a long, broad kind of evaluation, I want to learn this. And I feel like my conversations with Fatima, we've done this very, very well, and she does it very, very well with her research. How do we engage patients in care? I believe that we all do it very, very well, and those of us on the call know this and do this. And I believe that it is really about this active listening and going back to it over and over and over again, primarily, if we can, with people that look closer like the patients than we do. So clearly, I don't look like a lot of the young people that were experiencing homelessness, but what I would do is I would partner with the staff that could engage and could have relationship with them. And then once the young people had trust in our process, then I would insert myself in. But I think it's really important to know who we're talking to see who the bridge builder is, to build the bridge with them, and then be able to engage them in care. It's important that we have timelines. I have work groups that we have timelines, but that there's outcomes with each of the timelines, but we also have to have flexibility and honesty with our work group. Nancy's on a work group with us that we're looking at opioid use and abuse, and she's doing amazing work with us in the runway in opioid use and abuse with the free and charitable clinic sector. And what we figured out is we've met for a year, and now we have, as a result of this partnership, we have a state organization called TASK that is now saying we want to be able to provide case management and referrals for all of the people that are experiencing behavioral health challenges in your free and charitable clinic sector. And that's because they've been engaged in our partnership from the very, very beginning. So I do see that there's systemic impact as well as individual impact. And we always want to do evaluation along the way. So that's my presentation. Stop presenting, right? There.
Thank you so much. I think, I don't know, Fatma, would you introduce Dr. Ahmed?
Thank you, Melissa. Thank you so much for your amazing feedback on that. It has been recorded. I'm going to hear you again. You've set out some great example, and in fact, you have given me a process exactly the way to standardize some of the things that we do as a project manager, in fact. So if I create those documents, I'm sure going to share that with you. Excellent work. Thank you again. Yes, now I'll have the honor to introduce Dr. Tahir Ahmed. He is also from that prestigious institution called Advocate Christ Medical Center. He's the Assistant Program Director of Emergency Medicine Residency there. He's a physician that has graduated from Rush Medical College in 2014 and finished his residency in Detroit in 2017. He has been at Advocate Christ since graduating, and he is currently an assistant program director for the emergency medicine residency, as well as the residency global health director. I'd now give it to Dr. Tahir Ahmed, and he is very excited to do some really interesting work in the communities out there, in the Bridgeview, Palos Heights, Oak Lawn, that entire area. So with all due respect, Dr. Tahir, to you. Thank you.
Hey, salam, everyone. I hope everybody's doing okay and staying safe during this snowstorm. I was hoping I can also have one of our residents, Dr. Dana Okali, also talk with me as well. She has been spearheading a lot of initiatives that we've been working on. Dr. Oyen Okabanjo, she also essentially on a hospital and system level is somebody that's been working on addressing the needs of the community and has already organized several events and has started many partnerships. She wanted me to mention, she had to step off, a few of the things that are going on. And so I wanted to briefly mention that before we got in a little more to what some of our goals are. But she had mentioned that similar to what you were talking about with addressing some of the healthcare inequities, she has partnered with her and Jackie have partnered with the Chesterfield community in trying to address various healthcare inequities, access to care. In addition to that, at Trinity Hospital, there is a food pantry pharmacy program that's been ongoing. And so they basically have been working on that. Jackie also is involved with that. And additionally, also with UFC, there are some funding grants that they're trying to award to different organizations that are doing incredible work. As far as some of the work that we've started to get involved in and we would like to expand, this is particular what me and Dr. Dana Okali are working on. We have a trauma recovery center that's kind of based out of Christ that has gotten this amazing grant that's doing incredible work. As many of you know, Christ is a level 1 trauma center. And what happens is we have a lot of people who come through there who are victims of gunshot violence, stab wounds, even blunt trauma, as well as sexual assault. And so what we've noticed is that those people are getting care at the hospital, and then they're leaving the hospital and they're not, following up with anybody. And so Dr. Kim Miller essentially was able to come through with a grant and open up this trauma recovery center where these people can follow up there and they can get, to establish care afterwards, but also they can address the various needs that they have from psychological, social, all of the things that come with being a victim of violence. And that's been an incredible success. And in fact, there's work in progress to have a second trauma recovery center open up. And so some of the things that we realized is that we need to address what the needs of our communities are. What are the things that are missing? What are the things that are needed? And Dr. Dana Okali mentioned that we need to somehow come up with a needs assessment. And our program, we train 14 residents a year in emergency medicine, and we graduate them every 3 years, and they go out to work in the community, and they go to all different parts of the world of the United States. And so what we wanted to say is in our curriculum, we wanted to build that work ethic that allows you to say, I'm not just a doctor at this hospital, I'm not just going to work shifts, but I'm also a member of this community, and I need to serve the community in a way, in a capacity. And so that's kind of what our goal has been. And we wanted to reach out and partner with various organizations to be able to address those needs. Donna, if you're still on the call, I would, if there's anything else you want to add about that, I'd love for you to chime in.
Yes, I'm still here. Thank you everyone for having us with you guys today. Echoing what Thayer said, I think it's so important that we do the work in the community, but I think what's also so powerful is if we give our physicians tools to be able to take that learning to other institutions that they go to. We graduate 14 physicians a year, and we're not all going to stay at Advocate Christ or in Chicago. But if we have the tools to partner with communities and take that work elsewhere, I think that's so powerful. I think bigger vision-wise, that's also what we hope to create. One, a sustainable partnership with the Trauma Recovery Center, but two, also giving our physicians the tools to really go out and be powerful community members, not only in their emergency rooms, but on the greater community level as a whole. Melissa, thank you so much for your presentation earlier, just because I think you have highlighted some of like the crucial steps in order to building these partnerships. I think you oftentimes find people in the community who want to do the work, but don't know how. And there is so much strategy and intention behind building partnerships that I just loved so many of the points that you brought up. Having like a mission and a vision, identifying your stakeholders, identifying the needs of the community themselves versus just coming up with your own ideas and just going about doing work like that. So I'm so excited to hear about the work that this community is doing and the EMPART and building this free clinic, and excited to be a part of it, both on an informal and a formal level. But yeah, I think there's a lot of great work that's happening, and we're excited to be involved.
And, obviously we wanted to hear from the community as well. And so you guys have heard a lot. So we would love to, leave some time for people to interact or ask any questions or kind of move forward. So we'll definitely turn it back over.
Well, thank you, the Christ Medical team here. It's amazing that the kind of work you're doing, and of course, definitely, you're more than welcome to have all of the three join and have the panel there. And so the floor is to you guys. Anybody who wants to ask questions. So here's my first question to you. So what are some of your current community programs that people can simply join?
So honestly, I would say that from our perspective, me and Dr. Donna are working on like the residency level and kind of the training program there. So we're basically in our infancy, and we're trying to establish those partnerships. But additionally, we're also looking for different community organizations to partner with, to create projects or to join existing projects that have been successful and get exposure that way. I would say that Dr. Oyen Okabanjo has had several events, a lot of which have addressed and been designed to educate the medical community, but also the community at large on healthcare inequities that exist, and how, basically identifying where is it that people are not getting the same care? What is the problem with issues that result in different outcomes for different patients? And so those are some of the things we've been involved in. To be honest with you, we are looking to be aggressive in expanding what we're doing and creating a footprint. So I would say that at this stage we're in the process of trying to partner with even organizations like yourselves and trying to take advantage of this opportunity. We think the time is ripe to allow our medical center, but additionally just physicians in general, to get involved.
I see, Nabil, take it over. You're so great at managing these events. And Luma has a question. I'm going to mute myself now.
Thank you, Fatih. I appreciate it. Actually, I did have a quick question. Thank you, Thayer and Donna, for that introduction. Your work is amazing, and I am just so impressed. Just a little bit about me and why I'm so interested in your work. I kind of, you can say, represent Mecca Center to a certain extent. I've worked tremendously with the board there for community outreach programs and whatnot. I'm not sure if you're familiar with that area in Burridge, but I also work for Centene, which is a managed care company as well. And we are pretty much involved with insurance, but we have a great staff of care managers, social workers that collaborate consistently with primary care providers to help a lot of these Medicaid patients. So we are interested. And I think they already initiated a lot of the partnership with OSF and Christ Hospital, looking for, especially with COVID, innovative ways to kind of minimize costs, because it is a Medicaid plan, but also more patient-centered, more value-focused care. So that's something that interests us from a Centene point of view. But the other thing from my point is I'm actually studying PhD in organizational development. So my quest, I guess, this year is to see how we can better integrate primary care providers, community centers, and then more importantly, like pharmacists, because I'm also a pharmacist in training, or nurses. So, and I also have a public health degree too. So how do we put all these different pieces of the healthcare system together to be more efficient? And like another key issue with care managers is that they work a lot, like after they leave the hospital for hospital discharge. But they want to be more involved with the primary care provider, right? So they can be more effective in maybe like medical management, right? Like those things, or trying to see the underlying reasons for these behaviors of not seeing the doctor, so having them working better together is an ultimate goal that we have. So that's just a little bit about our focus. I just want to thank you so much. And I look forward to talking in the future too, about like how we can better integrate those different types of providers together.
That's an excellent point. You bring up a problem that we have. Our community healthcare workers at Christ specifically, and in the advocate healthcare system, something that they revealed to us when they came and did a town hall, just to kind of inform us of how they work, is that one of the things that they are doing is for these Medicaid patients, when they're trying to get them to follow up with primary care providers or even subspecialists, they are getting on the phone and just calling as many different places as possible and seeing who accepts that care. Now, the first thing that I thought of is that's an incredibly inefficient process for them. Their time is so valuable because they're dealing with such a huge amount of patients, and they're stuck there on hold just trying to figure out where our patients can go. And I think that's a problem within the system, especially, Medicaid is obviously known not to be an efficient program at all, but it just, to me, that bothered me because they're sitting there, they're trying to get our people plugged in, and they have to sit and wait and hold on a phone call just to get them some sort of established care. So I think the point that you're making is it's a dire need. It's an absolute necessity. If we can somehow make our system efficient, where our community healthcare workers, our patients, everybody, it's more streamlined, I think the care becomes better. The outcomes will be better too.
Thank you. Appreciate it. Thank you so much.
I totally agree. I just want to add something right there. So in our community health worker program that we designed for the EMPART project, I actually added the access to care component in that curriculum. So Dr. Rebecca Johnson co-edited that or co-authored the program, and she has a lot of resources, and she has actually also worked with the community, has put together a community health worker program for the research ministry in the past years. And we built upon that program and we added the MOS component on it. But in addition to that, we put in that additional access to care piece, which does take a lot of time. And I'm finding out that piece is missing out from the community health workers, the support that they get, because they're not formally trained. So that's another issue that we have. So but together we can work. And Luma, you're probably going to be one of the key people out there who are experiencing this firsthand. We're here. We'll connect with Centene and the Christ, and we build on that. Thank you.
Could I just throw a potential resource for your group to reach out to if you're looking at kind of a integrated access to care? We have a free and charitable clinic down in Bloomington, Community Healthcare Clinic, and they partner very well with their advocate hospital there. I think they literally have a clinic on the campus of the hospital. But, and you can't, it's Bloomington's different than the suburbs. I get that, but it might be worth, and I would happily broker a conversation for you to just talk about, they do things like, when you talk about specialty care. Now, they don't have big numbers, but the people go through the free and charitable clinic if they need specialty care. They know how to kind of screen like who needs the specialty care and who doesn't need the specialty care, and then they've actually had some kind of and I think on some level they share some EHR back and forth. And the free and charitable clinic there can actually provide real data about increasing the time between readmission rates that the hospital benefits from. They actually have a shared board of directors, you know, to kind of do an, that's like the very end of the finish line. But if you want to look at some models around the state, I would be happy to and you could just kind of pick apart and take what makes sense for you.
Thank you. That sounds great. Thank you so much, Melissa.
Hi, this is Nancy Romanchek, and I appreciate your conversations. I've been listening with very much interest. I'm a faith community nurse for many years, and I'm on a project for a grant through Advocate Aurora to lay the foundation for faith community nursing in the mosque setting in the Chicago area. I ran into a couple of hitches with COVID, but I'm very persistent. I've been doing this for many, many years. And it's again called to my attention that because of siloing, faith community nurses seem to be not recognized. But we're out there in the community doing a lot of work that you all are talking about every day. And part of the thing is, they're primarily RNs, but now we're looking at masters prepared, because when you're out there in a faith community nurse, you have to be able to function independently and make connections. So because of the spiritual piece, faith community nurses tend to be very quiet and do their work quietly for the pleasure of Allah. And so they're not visible except to the communities where they are involved and active. I've been a hospice nurse for like 10 years before I came back to faith community nursing. And because of my conversion to Islam, that's where my interest in the mosques came from. But the interdisciplinary care team that was used in hospice is really set the bar for interdisciplinary work. And I am struck when I did my nursing history course at University of Penn when I lived on the East Coast. It was so interesting to me how it seemed to be that nurses were out in the community doing the work. And then once they established it, more powerful forces would come in and take over and over again. They systematically dismantled the midwives, everything from that you could think of. And I'm seeing that happen again, because historically faith community nurses have not been attuned to research. They use evidence-based practice every single day, but they don't have that established unique body of knowledge that establishes a profession set apart. So right now we're finally at that point where nurses are becoming more aware of that. And I wanted to let you know that Advocate Aurora System has 26 faith community nurses in their network. And since the merger, we've added more across the border into Wisconsin. When I applied for a faith community nurse position at Islamic Foundation North, it coincided with the merger, and all of the positions were cut. They were funded through spiritual outreach. Do you see the benefit of that? If you have a grant-funded project for diabetes, you must focus on diabetes for a year or 2 years or 5 years. But while you're out there in the community, you see all these other things going on. When you're a faith community nurse, in a faith community, you know them, they know you, they trust you, you establish rapport, and you pivot. You're agile enough to know diabetes is caused because you got obesity. So you can set up an obesity program very quickly and address the needs as you identify them. And I did a health community assessment. You're talking about community assessment. That's why I'm bringing this up, which is geographically and appropriate for that setting. And you know exactly what you have in this small microcosm. And that's what you can address as a nurse. Now, if you have a nurse on the ground, she can facilitate these larger projects. And the reason that community health workers are growing right now is because they have funding, they're paid for. And the problem is faith community nurses have been written into the walls. And so they're not recognized for being funded for individual billing, but they can be because of Z codes. So right now we're on the brink of that. And my fear is that when people discover that, it's going to be exploited just like everything else. I want to see faith community nursing stay pure so that the nurses in that community or that cluster of mosque communities or churches can retain the ethnicity, the religiosity of that community and address the whole person care that's so central to community health. So I just want to say I hail and salute each of you. My heart is with you as we go forward in developing projects that COVID, this horrible thing, has given us the blessings on the other side for all the opening of these funding opportunities. And I pray that we all, recognize the concerted effort of our mission, and in the true spirit of Melissa and Miss Fatima, that we stay aligned and work at partnership. I see territorialism beginning, and I don't want to see it fall into that, because I witnessed what happened with our government recently. And and that's something we need to be aware of. And partnership building is so important for making those little tweaks that allow you to work together rather than in competition. And I'm just saying that because I'm seeing that already start with some of the free clinics, that there's a competitive nature to it, which is lovely because it brings a lot more to the table. But to get those forces to see that we all have the same mission and we need to work together, see where the pieces fit together for interdisciplinary care, which is the most effective for patients. So just don't forget your nurses and your social workers and your community health workers all fit together.
Thank you, Nancy, for saying that. I really appreciate what you're saying, and I echo that sentiment. I think when I hear you speaking about all the work that's being done, all I see is an opportunity for all of us to come together and be stronger, as opposed to some sort of territorial kind of approach. So obviously, I want to just say thank you, and I appreciate all the work that you're doing. I know everybody does, so thank you for that.
And I want to say territorialism is not from this group. I know.
I hope not.
I'm lecturing to the sages here, but I'm seeing that happen, and you really have to build your stakeholder community and really be a unified force to prevent that from happening and purify your intention. Why are we doing this and how are we doing this? And really, it's all about the patient. I see academics getting involved where they hadn't been before, and that's concerning to me because research is as good as it is. I don't want to lose the forest for the trees if it's going to be a matter of publishing a paper or really taking care of the patients right now. I think you have to really keep the balance, because without the research, you can't really establish and go forward. But if you focus too much on that, you kind of lose that agility and ability to really pivot.
We had a question in the, we have a comment and a question in the chat. Comment from Brother Seth: these topics are so important. For my MPH capstone, I looked into Chicago-based FQHCs while working at CTPH, and a major issue is a disconnect between government and community in terms of communication and data exchange. And I think the question is sort of actually builds off of that, as well as the conversation from Dr. Johnson. And I think, I think this question could go to both, I think, the Christ Advocate team and Melissa. What do you see as the barriers to engaging community patients and caregivers in the community who may be uninsured, or even if they're insured, are unsure of the health system or uncomfortable? How can we overcome these barriers?
I think just from my own experience working in the emergency department, interacting with the patients every single day, is I think the communication by the health system has not been up to par with explaining what the next steps are and what the resources available are. And I think what I found, and Donna can jump into, is when our patients are more informed about what is available to them, they tend to utilize those resources. So, when I let patients know that somebody's going to be reaching out to them and they're going to be asking about this and they're going to coordinate a primary care appointment, I get a message back saying they scheduled their appointment, they're going to be going to their appointment. as opposed to me just giving some papers and saying, hey, on this paperwork, you'll find some things to follow up with. So I think one of the biggest barriers is effective communication by the healthcare providers, in the sense of trying to say, what are the next steps, how to inform our patients. I think it's just a matter of us not speaking at the same level as our patients. We speak in medical jargon, and we're not speaking English, right? And so, or Spanish or Arabic or Polish or whatever it is our patients are speaking, we're not speaking the same language. We are using terms that, maybe other physicians understand, but we're not speaking the language, that people can easily understand. And then they will take that information and they will act on it. They'll utilize what the resources that we provide for them. They'll follow up with physicians or with specialists. They'll participate in community events. If we're able to do that, I think that's effective. So that's what I can speak on from a clinical aspect, at least. Don, I don't know if you have anything to chime in about that as well.
Yeah, I would definitely add that the biggest limitation of our practice, specifically in emergency medicine, is that we're almost like temporizing physicians. I think a lot of the patients that come in who really need resources need someone who's going to manage their care long term, over years and over their lifetime. I think the beautiful thing about emergency medicine is that we don't discriminate. Anyone walks through our doors and we can care for them. But the hard thing is when they need that long-term care, we're not necessarily the people who can give it to them like one-on-one. We can link them up with resources, but a lot of the disconnect falls when we are not the people who can carry out kind of that long-term care. So as they are saying, I think as we become more explicit with our patients about next steps and following up, and kind of owning our part on patients falling through the cracks if we aren't clear on our directions, or if we don't put in a little bit of the legwork in making that first phone call to the community health worker, or following up and making sure that that patient got an appointment, that our patients do fall through the cracks, and that's where we as physicians can do better on our part.
For sure. And then another thing I would just comment on, just because it was mentioned in the comment about the government role. I think it's no secret that when it comes to healthcare, our government is not the best administrator of it, nor is it the most was essentially in charge of the testing that was done. So if somebody came in, had COVID-like symptoms, we would test them, and then we would send that sample to IDPH. Now, in order to do that, to get approved for that test, we had to call IDPH and say, hey, I have a patient here, they're exhibiting symptoms of COVID, I want to do the testing, which is an absolutely essential component at the beginning of a pandemic, right? We want to identify who has it, we want them to isolate, we want to do some tracking, community tracking. And what we found is IDPH not only wasn't working during during non-business hours when patients are coming in at all hours, they hadn't planned for that, they were 9 to 5, but also it was impossible to get a hold of them on the phone. I mean, we were, you'd get on the phone and you would be in the middle of a shift and you'd have somebody that's really sick or somebody that's exhibiting these symptoms, and you're just sitting there waiting, and sometimes the line gets disconnected, sometimes you get a voicemail. And so it let me know that I can't rely necessarily, if we're going to, as a community, we need to partner with the government, obviously, in terms of Medicaid and figuring out, but we can't rely on them to be the saviors or to initiate programs that are going to help the community. It has to come from the work that organizations like this one is doing, from the work that all of these people are coming together trying to do, to say, these are the needs of the community. This is what we need. We need to be pushing for the next steps in terms of addressing healthcare inequities, access to care, healthcare literacy. That's going to come from us partnering together and speaking very loudly.
Yeah, and I would just add an echo and be encouraged by the conversation that's occurring today, because this is encouraging. I would say that, I'm going to say, ask the people, right? Ask the people why they're not coming, right? And put the money in a research project to ask the people, right? Put the money in asking some residents to ask the people. So, and you and I all know when people are in crisis is when they're most open, right? And then the crisis goes away, and then the rationale kicks in, and it's like, I don't need to take this med or whatever. But I just wonder, as somebody's exiting, like we at our clinics, we're going to start a voluntary, because we don't fund our clinics. They fund themselves. They're amazing. But we have an eval project that Nancy's clinic it was engaged in, and we are saying you can ask every patient, if the clinic wasn't here, where would you go? 25% of them said they'd go to the emergency room, right? So I just wonder if you had, just a certain month that you would just ask your patients key questions about what's keeping you from following up, right? Why? Or I think we would get some nuggets. I would also say, please, look on our website and look for free and charitable clinics in the community. And if there's anything the free and charitable clinic can do, we'd love to partner to figure out a way to kind of engage. We don't have a lot of clinics right now in the, that's why we're so excited about the partnership that we're developing with Fatima's work. But I do think that free and charitable clinics are designed like that. And this having available residents that are looking for something to do, there is a student-run free and charitable clinic association where if students are interested in being involved in free and charitable clinics, they could get lots of resources and maybe identify work groups that they could be involved in on a more national basis, and then bring it back and say, you might not need to have a whole student-run clinic in your hospital, but there might be practices that they're learning across the country. There is a student-run clinic up at Rosalind Franklin Medical School. They take one of their clinics, and on Thursday night, the clinic closes and it's a student clinic, right? And then the students are there to provide the healthcare. So I just think the student-run model will kind of help with this question.
I wanted to tell you, I'm completing a medication access project through Melissa's a grant for medication access at our free and charitable clinic. And I just was so interested at the surveys. This was in the Somali Nigerian community in the city, because when our clinic closed for COVID, we had some money on the table. So I offered them blood pressure monitors and glucometers for home use. And here's the first one that I look at. Has your doctor told you have blood pressure? Yes. Their pressure is 166/94. And would having a monitor at home to help manage your symptoms during COVID be helpful? Yes. Why? Less trips to the ER, plural. And then, would it help if a nurse talked to you on the phone, or if you had a nurse from your community? And it turns out they speak a different language. They speak Somali language. So they would have to have somebody who understood that language, understand their worldview, and trust is a big issue in this community. So it's so interesting to me, that their responses are exactly what we're all talking about, but here's your proof. We just gave away 36 of these, 39 based on their needs. And then we surveyed them before, and now after 3 months, we'll survey them again to see how it was helpful. And we also we did a webinar last Sunday about topics, and the faith community nurse there is working with that community. So see that impact on a very granular level. Who is going to follow up with these patients? They might not even trust their doctor, or they might not have a doctor. But when they're in their faith community, they're very comfortable. So that's just a thing I just want to throw out there again to reemphasize the point. If you have a free clinic, and as faith community nurses, I'm in partnership as a free clinic because I'm doing the same work from a slightly different perspective, but I'm still community health. It solves a lot of problems on a very small level with small numbers, one faith community at a time, which is how you have to really start that grassroots effort. And I had nurses when I was in Wisconsin. I had nurses from Edgewood, University of Wisconsin-Madison, and those student nurses would come in and do all kinds of projects. So once you establish that boots on the ground, you can have facilitation of individual projects for students and groups that are interested in doing projects or in some particular topic, because there's so much work to do,
Sister Luma, I know you've had your hand up for a while.
I'm sorry. Thank you, Nabil. Appreciate it. Okay. I love everything you just said. And I just honestly, it's more of like a recap of the points that are very interesting, but also a bit of a tangent when it comes to like structures and systems. Dr. Thayer started off with saying that, it's a system issue. And I completely agree with that, because, and I also agree with Melissa too, that we're not even asking the patients. But also what Dr. Thayer said, put yourself in the shoes of that specific doctor. Our system, or the way that we've been taught or trained, especially medical doctors or pharmacists, in any way, very black and white, medical jargon, we barely figure that out, all these guidelines. The education system in and of itself has not been well integrated when it comes to community or even just social determinants of health. It's a very new concept. It hasn't hit the grassroots of a lot of institutions. And what does that mean? So a few things that just crossed my mind is like, currently they've changed like some taxonomy codes, and they're trying to incorporate that recently of types of social determinants of health. So it's not just, diagnosing based off of like a condition, some of it like abuse or like they've had issues with their family. They're trying to interpret those specific social issues, and find a better way to interpret and bring meaning out of it per patient. The other thing that I thought about when it comes to like Dr. Thayer and Melissa is maybe when that patient first comes into the system, the structuration process of how we're going to find a way. It could be as simple as starting, are we asking the right questions, right? And having that integrated, especially for doctors that do not have time. I mean, they're talking about really high intensive ER issues. They're not going to be able, I think, mentally to worry about all the small itsy-bitsy things. So even incorporating it within the automated system, when they check, I know you guys have to write all your notes and whatnot, some type of either questionnaires that are included when they see these patients. And that question, if anything says yes or no, there's a process that is provided, or it directs the doctor to take these following steps for specific procedures that help that doctor, because I feel like our system is a lot top bottom. And as you said earlier about the government, I think government has very good intentions. I don't think it's about intentions, but it's just that government is so up high over here, right? And there's a disconnect between what they're doing and then what we're currently experiencing as institutions and these private corporations or hospitals or even insurance companies. And then you've got the workers here that are dealing with a totally different issue of practicality. So decisions get made from the top, but doesn't mean they're practical solutions at all. So I think what both of you said, I'm a big fan of starting with the research, maybe even starting with like, what kind of questions can we incorporate? And I think it'll make a big difference, even if you start small with like specific chronic conditions like diabetes, and then we start seeing the benefits of it and the outcomes, we can take it on a more global or a national scale and be able to implement it if we have some type of process at the end of it, or like templates. That's my story. I'm sorry, I talk too much, sorry.
No, these are great points, Luma. Yeah. I have a question for Dr. Thayer and Donna. I know Christ also has a case management unit where the patients are case managed through, and I know they are inundated. Does that case management unit works as an end of the line, or do they have some say in how to handle the outcomes? Or do you have an outcome measures set in that this executives review?
Yeah, we do. That's a great point. I think I think Donna actually just recently went through the report, but essentially every single year, specifically Christ Medical Center needs to come up with a community needs assessment for the communities that we serve. What are some of the goals that we set? So I believe for the 2019 and to 2020, some of the goals were improvement in management of diabetes, access to care. So they have specific markers, and then they also need to do a needs assessment based on who we're serving. And as a result of that, that's how our programs get launched. And that's how, we as a multidisciplinary team will come together and say, this is what's feasible, this is what's needed, and then this is what still needs to be addressed. And so that happens on an annual basis, and that's kind of what happens with the leadership teams at Christ. They review that and they decide, what the markers are for success and for failure. And so that's what happens. But to be honest with you, I wasn't even aware of this until recently when I was just looking for it myself to see what has been done. And so I don't know. I really don't know how much of an emphasis is on it. I can't speak to that. But I know that that's some of the work that's being done. I know case management is involved with that. But if you ask any of our case managers, is there more work that needs to be done, or what else do they need? They'll tell you. They are definitely, the word you used was inundated, and that's the perfect word. I mean, they have a lot on their plate, and they are constantly trying to serve our community, but they don't necessarily have all of the resources or tools at this time.
Yeah, we have. I think we've identified some opportunities where we can begin to address that. And again, with partnerships is going to be crucial with among all community stakeholders like payers, healthcare systems, community-based organizations, and some of the and in fact faith-based community component is going to be crucial, as well as other grassroots volunteers that are individuals, and they're working as individuals, and yet they are looking to be incorporated. And one of the great point that Saf made, that there are professional students or the students, they are looking for professional volunteering opportunities where we could bridge these gaps. And so hopefully, inshallah, we move forward from this. And there's a lot of take-home points that I jotted down, and hopefully that would come out as new programs in their community. And all of you guys are actually a part of these programs. I'm really hoping that we could get some. And Nabil, let's actually get the meeting minutes for this particular one, because I see at least 2 programs coming out of this meeting. Alhamdulillah.
Well, thank you guys for doing this. This was awesome. I love that I was part of this, and I'm now excited about kind of what are the things to come. One of the things I was worried about is with COVID. Obviously, so much attention needs to be dedicated to that. I was worried about a lot of other issues that needed to be addressed kind of being swept under the rug. And I think things like this are going to really help identify a lot of problems and hopefully be of some benefit to our community members and to our patients.
Thank you for including me in this call. I mean, you are just an amazing, powerful, impactful group. So just feel privileged and honored to be able to be invited to the call. So thank you.
Yes, thank you, Melissa. It's an honor for us to have you. Thank you, Dr. Tahir Ahmed. And thank you, Donna and Dr. Okibanjo. I think she had to go visit a patient. I saw her in her full gear. Please say my regards and thanks to her. I saw Dr. Kamal Adarawi actually joining the call, but I'm not sure if he's on the call anymore or not. But hopefully we will connect with him as well as a connector with the community. He's also he's out there at UIC running a community health program too. So he's a good component, and he's actually from the Department of Nursing, so he bridges this gap with the community health workers and the nurses and the healthcare systems. So we do have pretty much all the different partners that it could take for the program to get going, and I'm very hopeful that in the next couple of weeks, literally in the next couple of weeks before February is over, inshallah, we should have some kind of a program going in that community. Thank you very much. Thank you all.
Thank you. Stay safe, everybody.
Everyone too. Wa alaikum assalam wa rahmatullahi wa barakatuh.
Thank you.
Thank you, everybody.